All right, in this lecture of the genetics unit, we're going to be talking about X-linked dominant diseases. So first, we're going to give you an overview of X-linked dominant inheritance. Now, it can affect both males and females, which distinguishes it from X-linked recessive. And as a result of that, it's going to be present in all generations. So it does not skip any generation like a recessive disease. So here we have this pedigree. So you have the first generation here, second generation here, third generation here. The squares are males, the circles are females. The colored circles or the colored squares are diseased. And then the clear squares or circles are healthy. So now we'll briefly go over some rules of inheritance for X-linked dominant. So if you have an affected male, as a father, he will pass the disease on to all of his daughters and not to any of his sons. So there's no male-to-male transmission in X-linked dominant. So let's look at here. We have an affected male. His wife is healthy. And so you can see all three of his daughters are affected and neither one of his sons are affected. So let's look at the inheritance here. So you have a father here, you have an XY, then you have the mother, two X's. Now their daughters would have inherited one X chromosome from the father and one X chromosome from the mother. Now from the mother, both are healthy, so it doesn't matter which one they get. That X chromosome is going to be okay. From the father, they can only inherit the affected X chromosome. So that's why 100% of the daughters will inherit the disease, because they have to get one X chromosome from their father, and the only one they can receive is the affected one. Versus the sons, so if we go over here, so all the sons are going to inherit the Y chromosome from the father, and they're not going to inherit any X chromosome from the father. So there's a 0% chance of them getting the affected X chromosome. And then from the mother, they'll get one of these two healthy chromosomes, and that will give them their XY. Now, if you have an affected mother, on the other hand, she will pass the disease on to 50% of her daughters and 50% of her sons. So we look here, here's an affected mother. Half of her daughters are affected, half of her sons are affected. And then you look at here, we have another daughter here. She's affected, half of her daughters are affected, half of her sons are affected. So let's take a look at this. So you have a healthy father, and then you have a mother with a affected X chromosome. So for the daughters, they will get the X chromosome from the father, which will be normal, and then they're going to get one of these two X chromosomes from the mother. So they have a 50% chance of getting the affected X chromosome, and then they have a 50% chance of getting the unaffected X chromosome. So that's where this 50% comes from. So let's look at the sons. So the sons are all going to inherit the Y chromosome from the father. And then again, they're going to get one of these two X chromosomes. So they have a 50% chance of getting the affected X chromosome and a 50% chance of getting the healthy X chromosome. And so that's why half the sons also can potentially inherit the disease. One thing to note is that women will express symptoms of the disease if they inherit the affected X chromosome, but they're less severe due to the presence of that additional X chromosome. So with women, they have two X chromosomes. They'll have one that's affected and one that's normal. The one that's normal essentially compensates for having this affected X chromosome. Versus the males, they have an affected X chromosome. They don't have another one to compensate. They just have the Y. So that's why the symptoms in males can potentially be more severe. All right, so now we're going to go over these 4 diseases that demonstrate X-linked dominant inheritance. So Rett syndrome, this is due to a mutation in the MECP2 gene. And when it's mutated, it's abnormally methylated. This is a gene that's involved in regulating gene expression. So as you'll see, when it's infected, it can have significant devastating effects. The majority of cases of Rett syndrome are actually due to spontaneous mutations. However, the ones that are due to inheritance are inherited in an X-linked dominant fashion. So that's why we're talking about it in this lecture. You'll only see it in young girls because males usually die before birth or shortly after birth. The clinical features of this disease, it's really due to 2 things, neurodegeneration and then behavioral problems. And in fact, for a long time, it was thought of as more of a psychiatric illness. It was part of the DSM. Since discovering the genetic causes, it's been removed from the DSM and thought of as more of a neurodegenerative disorder. However, the behavioral aspect is still very important. And it consists of regression of social, verbal, intellectual, and motor abilities. So what happens to these patients is in the early stage of the disease, they undergo development, they'll even meet some milestones, but then they regress later. And that both in terms of neurocognitive function and then also in terms of behavioral function. A characteristic of the disease is repetitive hand-wringing movements. So clasping hands, wringing hands, that's something you'll see a lot. Repetitively touching their face, other repetitive hand movements. When the patient begins to undergo the later stages of the disease where they undergo more neurodegeneration, they can develop ataxia and they can even have seizures as well. And then unfortunately, they have a loss of developmental milestones as they progress through life. Diagnosis for this disease involves recognizing the symptoms and then confirming through genetic testing. Unfortunately, there's no cure for the disease. The management really consists of treating the symptoms, such as the seizures or the behavioral aspects. So next we'll talk about hypophosphatemic rickets or vitamin D resistant rickets. This is due to a mutation in the PHEX gene. And this is on the X chromosome because we're talking about X-linked dominant disorders. Now, the end result of this mutation in the case of this disease leads to decreased 1-alpha hydroxylation of vitamin D in the kidney. Now, what happens between here and here is not important, it is not high yield. What you want to know is that this is the end result. So we'll talk about vitamin D here for a minute. So you get it from the skin, and remember we get exposed to UVB light, and we get a precursor known as vitamin D3, which you can also ingest in your diet. Then this undergoes hydroxylation in the liver by 25 hydroxylase, and that gives you calcidiol, which is a precursor, and then calcidiol undergoes further hydroxylation in the kidney, which is where this comes in, by 1-alpha hydroxylase, and that gives you calcitriol, which is the active form of vitamin D. Now, in this disease, if you don't have this last step here, you're still getting all the precursors. You just don't have this last step, and so you don't have the active form. So you have, overall, the end result is decreased vitamin D. And you have decreased vitamin D, you're going to have decreased absorption of calcium and phosphate, both in the kidney and the GI tract. And that can result in significant problems. Now let's go back to the text here. So we've said this already, abnormal kidney function. They cannot resorb phosphate in the proximal tubule of the nephron. If you're not reabsorbing phosphate in the nephron, you're going to lose it in the urine. So you're going to have a high phosphate content in the urine. And then as a result of decreased calcium and phosphate, you're going to have symptoms that are similar to other types of hypophosphatemia and vitamin D deficiency. And so you're going to have rickets, and then as a result of that, you'll have bone problems. And the reason you develop that is because calcium and phosphate are key components of the structural integrity of bones. And so if you have decreased vitamin D and decreased levels of calcium and phosphate being reabsorbed in the nephron and being absorbed in the GI tract, then you're going to develop structural problems with your bones, which will give you that rickets-like presentation. This disease can also lead to renal tubular acidosis. The way this disease is treated is where you just give them oral supplements of vitamin D and you give them oral supplements of phosphate to help to correct this. So Alport syndrome is a disease where you have genes that are mutated on the X chromosome that lead to type 4 collagen being defective. And type 4 collagen is an important structural component, especially in something what's called the basement membrane. And this is an important structure in epithelial cells that are involved in absorptive processes. And you'll see where that's important on the next slide for the kidneys. It also affects collagen that are present in the eyes and in the ears. So you can have visual defects and hearing defects. And so in the kidney, a key component of the glomerulus, which you can see here, this is a zoomed out picture of the nephron, and here's the glomerulus here. And then you have a zoomed in picture here with the renal corpuscle, the afferent arteriole bringing the blood in for filtration, the efferent blood bringing the filtered blood out. And then you have the renal corpuscle, which is involved in the first step of filtering the blood and to form the urine. And so you have it come in, and then it enters the nephron and to go on further reabsorptive processes. An important part of this barrier, though, of this filtration apparatus in the glomerulus, is the basement membrane. And a key component of that basement membrane, like basement membranes in other locations, is collagen type 4. And when you're missing this, you're missing a key component of the basement membrane, a key component of this filtration apparatus. And so what happens is that this basement membrane eventually splits apart and it becomes very weak. And what's important for that is that the basement membrane serves to essentially keep proteins and RBCs and other cells like white blood cells and other cells from spilling into the ultrafiltrate, which eventually becomes the urine. And so if you have a breakdown of the basement membrane, then proteins and RBCs can eventually spill in. And then that's where you develop significant problems because you're going to affect kidney function. You can get what's called RBC casts, and it really compromises the function of the kidney to effectively filter the blood. And so this can result in what's called nephritic syndrome or glomerular nephritis. And you have on EM or electron microscopy, you have this basket weave appearance. We just put this in here because you could see this on an exam, and it's really where the basement membrane breaks down, and then you kind of have an inflammatory reaction where they try to rebuild or repair the basement membrane. And it kind of has this weave-like appearance like that on electron microscopy in the basement membrane. So that's where that term basket weave appearance comes from. So clinical features, again, you can develop glomerular nephritis, hematuria because you have those RBCs that are spilling in, which can actually eventually, in the nephron here, so if we draw the nephron here, if you have enough red blood cells that spill in here and they get broken down and kind of clogged up in here, they end up clumping together and forming what's known as an RBC cast, and you can see these in the urine. Now, in the eyes, you can have visual problems because you can have lens dislocation because collagen is such an important part of many structures in the eye, retinal problems, cataracts, and then you can have hearing difficulties as well, specifically sensorineural deafness because it's a problem inherent in the structure of the ear due to this collagen being deficient. So lastly, to close this lecture out, we'll talk about Goodpasture syndrome. So like Alport syndrome, Goodpasture syndrome involves type 4 collagen, but it's a little bit different mechanism. So remember Alport, you had a mutation that resulted in deficient collagen 4, right? Versus Goodpasture syndrome is caused by antibodies. So it's an autoimmune reaction. Autoantibodies against type 4 collagen in the basement membrane of the glomerulus of the kidney and then the alveoli in the lungs. So essentially anti-glomerular basement membrane antibodies. So remember this picture when we talked about Goodpastures. Here's that basement membrane, this thick line on the diagram that represents this structure that helps keep out, remember, proteins and cells, mainly red blood cells. And then here, this diagram here, remember the lungs, you have the trachea like this, and you have the lungs kind of like this. And the trachea splits off into these branches, right? And then at the end of these branches, you have these little sacs that are alveolus. And so it would essentially, if we blew one of those up, and here's your alveolus right here. Here's your membrane. Here's your basement membrane, which is where the antibodies are coming in Goodpastures and attacking this. You have the basement membrane for the capillary. And this is where O2 that's breathed in from the air then travels across this epithelium, across these basement membranes, across the endothelium and into the capillary. And then CO2 that was collected from peripheral tissues by red blood cells is then released from the blood into the lungs so they can be breathed out. So you have significant damage to this membrane as well. And then just for a quick immunology tie-in here, this is a type 2 hypersensitivity. Remember, there's different types of hypersensitivities, and it's type 2 because it's antibody mediated. And then it's also associated with HLA-DR2. This can often be a test question as well. Now, just to briefly talk about the kidney aspect of Goodpastures, here's some histology. This is a section from a kidney of a patient with Goodpastures, and it's a PAS stain. And you can see these crescenteric shapes right here. You can see where there's significant dense staining here. And this represents all that damage that's occurring to the basement membrane and inflammation, really. And so that gives this characteristic look on histology for patients with Goodpasture. So you could see an image like this on an exam. Another thing is immunofluorescence is often done for these patients, and this is often used for diagnostic purposes. And what you'll see on immunofluorescence, it's usually a green, and it's usually these thick green lines, just like this red here on the PAS stain. But on immunofluorescence, it's going to be these thick green lines that are all throughout. And that's because you have the basement membrane like this, right? And you have all these antibodies that are coming in and binding to the basement membrane, binding to the collagen in a straight line like this, all across the basement membrane. When you do an immunofluorescence, you're adding a immunofluorescent tag. And so these tags come in and they bind to these antibodies that are binding to the basement membrane. And so then that gives you that flare, that straight line green appearance on immunofluorescence. And it's characterized as a linear pattern of IgG deposition. That is what you're observing on immunofluorescence. Now for the clinical features, you're going to have necrotizing vasculitis in the lungs. And then in the kidneys, because of all this damage to the basement membrane in the glomerulus, you could have necrotizing glomerular nephritis, or RPGN. Now RPGN stands for rapidly progressive glomerular nephritis, and Goodpastures can be a potential cause of that. We talked about this with Alport's. You can get nephritic syndrome, which is marked by rapid deterioration in renal function, because if you have all these antibodies coming in and really damaging, you can see where, if you look at the shape of the basement membrane, this is where you get that crescenteric look on PAS stain, and then that linear deposition of IgG on the immunofluorescence, is because really the whole basement membrane is getting damaged. And remember, as a result of that, it's complete breakdown of the structure. So you can have proteins leaking in, RBCs, which will give you hematuria and red blood cell casts in the urine. You can have azotemia, oliguria, and then hypertension. And unfortunately, because of this significant breakdown of the basement membrane and deterioration in renal function, these patients have a very poor prognosis and often end up having to go on dialysis and eventually get a kidney transplant. It's also a potential cause of restrictive lung disease. So you have the lungs like this, you have the trachea, and then remember it branches out like this, and branches out like this. And you have your alveoli like this at the end of these. Now, if you have all this inflammation, so you have all these antibodies that are coming in and binding, and this is causing an immune response. So you're having all this inflammation in here. As a result, you're going to have inflammation all throughout here. Now remember, the lungs need to expand to create that pressure gradient to bring air in. If you have all of this interstitial disease, interstitial lung disease, it's going to make it much harder to expand. And as a result of that, you're going to have decreased lung volumes. So it's truly restrictive lung disease. Now, just a little bit of physiology here. Because of this, because you have this thickness here, increased inflammation, damage, the O2 has more to travel through to get into the capillaries. To have efficient gas exchange, you need to have this barrier between the alveolus and the capillary be as thin and short as possible. And so that'll help the O2 travel very efficiently. The thicker you make this and the longer you make it, by putting in inflammation and all this and damage, that decreases the efficiency of gas exchange. So it decreases pulmonary diffusing capacity. As a result of that, you're going to retain more oxygen in the alveolus, and that'll increase your alveolus arterial gradient. So large A is for the alveolus, small a is for arterial or capillary. And so the difference between the PO2 in the alveolus and the PO2 in the capillary is going to be even further increased because you're retaining it as a result of this decreased pulmonary diffusing capacity. So not only does it destroy this basement membrane, as a result of that, it causes all these dysfunction in gas exchange and pulmonary function. So the treatment for this disease is plasmapheresis, because you want to help it filter out the antibodies, which are the source of all the problems in this disease. All right, and that closes out our discussion of X-linked dominant inheritance, and then some examples of diseases that exhibit X-linked dominant inheritance.